Okay, welcome everyone. Good afternoon to Aptive's Health Perspective series. Hopefully we are all here to learn today about the deaths of despair and homelessness and the mortality rates. We have our guest speaker, Courtney Pladsen. To kick us off before we get started, I will pass the mic over to Dr. Jason Ormsby.
Thanks, Jesse, and welcome everyone. It's wonderful to have so many people gathered who have a firm dedication of vulnerable populations. So thanks to all the great Aptive professionals that have joined this session, but also many of our friends and our colleagues from other organizations that have the same focus. So I am Jason Ormsby. I'm the Chief Healthcare Officer here at Aptive. I have the pleasure of kicking us off, so thank you. And today is our third Aptive Health Perspective series. And what this is, it's an effort on our part to educate our colleagues on important issues and in the process improve the lives of others. It's lofty, but it's our goal. The first session was with Ms. Kana Enomoto, who was our partner from McKinsey and the former director of the Substance Abuse and Mental Health Services Administration, or SAMHSA. And she talked about mental health issues in America. The second was Chris Steno from Deloitte, also our partner, talking about Health Prism, which is this innovative way of managing population health for vulnerable populations. And today, a great pleasure to hear from Dr. Courtney Pladsen on homelessness in America, who my colleague Jesse will soon introduce. But just some quick protocol during the presentation. We'll leave our cameras off and mute our mics until Dr. Pladsen's presentation is complete. And then we'll turn on our cameras for a discussion with your questions. She graciously will accept your questions and we'll have a discussion. So now I'll turn it over to Jesse. Jesse Castillo, my colleague, is a health system focused epidemiologist, a client development manager here at Aptive, and she's also the lead of our SAMHSA team, which consists of our partners McKinsey, Deloitte, W2, and the National Healthcare for the Homeless Council. And so now to you, Jesse.
Thank you, Jason. And I have the pleasure of introducing our guest speaker, Dr. Courtney Pladsen. As Jason mentioned, she is the Director of Clinical and Quality Improvement at the National Healthcare for the Homeless Council. She has over 15 years of experience in working in emergency departments and in federally qualified health centers. She's led national initiatives to improve the delivery of primary care, substance use treatment, and mental health for people experiencing homelessness, is one of our partners on our newly awarded SAMHSA IDIQ. And also, in addition to everything else she does, directs training and quality improvement initiatives, contributes to research and policy, and coordinates with partners across the federal government on emerging clinical issues affecting the homeless population. Today's presentation is about rising trends of deaths of despair. So the mortality data has demonstrated that these deaths have disproportionately impacted people experiencing homelessness across the country. So Dr. Pladsen will be presenting on data, gaps in research, and where we go from here as a country. And also wanted to point out, for those who may be new to Zoom, there is a chat feature if you would like to add in questions throughout the presentation. And as Jason mentioned, there will be a Q&A session after the presentation. And I will stop sharing my screen to pass it over to Dr. Pladsen.
Thanks, Jesse, and thanks, Jason, for the introduction. All right. So just to start, a few things. I know that supporting and working with people experiencing homelessness, it might not be everyone's role in which you come to this conversation today, but my hope is that you leave with a gem, with one idea that you can take back to your work, because the way that I look at it is that if we can design health systems for some of the most marginalized populations, if we can think through developing care teams that support some of the most complex, if we can design interventions to address overdose mortality, for this really high-risk population, then we're going to help everybody. And so there's some innovation within this work that I think is applicable across health systems that I hope that you all can take and apply it to the work that you all are doing. And just for the flow of the presentation today, I want to spend a little bit of time in the beginning just explaining the work that we do at the National Healthcare for the Homeless Council, introduce you to our organization. I'm going to do some level setting around just around healthcare and homelessness and the outcomes, and then talk specifically about mortality data and then some strategies that we're employing to address that mortality. So let's dive in. And as Jesse said, if people have questions throughout the presentations, please go ahead and ask. We're going to kind of cover a lot of information. So if there are things that you want me to do deeper dives in, things you want me to clarify, please feel free. These slides will be shared, and I put in a lot of links and all the research articles embedded within the notes. So if you need additional information or you want to do deeper dives, all of that will be included in what we share afterward. So who we are. At the National Healthcare for the Homeless Council, we really believe that homelessness is unacceptable and that every person has the right to adequate food, housing, clothing, and healthcare. And really that healthcare and housing are human rights. We believe that all people have the right to participate in decisions affecting their lives and really the right to self-determination. And that contemporary homelessness is the product of conscious social and economic policies that have retreated from a commitment to ensuring basic life necessities for all people. And that the struggle to end homelessness and alleviate its consequences takes many forms, including efforts to ensure adequate housing, healthcare, and access to meaningful work. And that feels important for me to share at the outset, just the frame in which we're coming to this conversation. And really, we're grounded in human rights and social justice. And we believe that we're part of the movement to end homelessness, that people deserve really high quality healthcare while they're currently experiencing homelessness. So these are part of the aspects of the work that we do. So we receive HRSA funding as a national training and technical assistance provider. So we do provide direct technical assistance to health centers to the 1,400 FQHCs across the country. We have a policy and advocacy arm in which we advocate for policies to help increase access to healthcare, decrease barriers, to address housing. So we have a wonderful policy advocacy team. We work on support best practices, we do research, and we really do a lot of work supporting people with lived expertise, coming to the table and having them share their voice. We want to make sure that we're bringing consumers alongside us. And by consumers, these are individuals that self-identify as people that have received healthcare in healthcare for the homeless health centers previously. They're people that have experienced homelessness. And so having their voice at the table is essential for us to be able to create adequate solutions. We always know people closest to the problems are closest to the solutions. So we have a National Consumer Advisory Board who helps direct a lot of our work and helps write and be a part of our teams. We have representation on all of our committees of people with lived expertise. Of the 1,400 health centers across the country, there are over 300 that specifically receive 330H grant funding to be healthcare for the homeless providers. And so those are really the health centers that we seek to develop deep relationships with. So as a clinical director, I occasionally do site visits. We do a lot of training. We support peer learning through learning collaboratives. We do a lot of work really building relationships and getting to know the leaders and the staff within these health centers. So much of this work is through relationships, and the healthcare for the homeless community is robust. It's a really beautiful community, and every time we have our national conference, it's like a family coming together. It's a really wonderful group of people doing this work all across the country. I know many people have heard or seen recently the article about Dr. Jim O'Connell, who is a physician out of Boston's Healthcare for the Homeless program, who's been doing street medicine for over 30 years. And I love Jim. I know him. He is a wonderful human. And there are so many other Jim McConnells all across the country doing that same exact really amazing work. So he is wonderful, and there are many people like him too. The other part of who we serve and who we work with is, as a nonprofit, we are not part of the federal government, but we work really closely with federal partners. I meet every 2 weeks with leaders from HUD, VA, HRSA, CDC, and others, really because we sit at a unique intersection at healthcare and homelessness. And so part of our role is bringing that to the table of how do we better coordinate across all of the federal government to do this work. And especially during COVID-19, that helped the COVID-19 response, specifically for people experiencing homelessness. We realized that no one federal entity held the key. It felt really important to bring everyone to the table to come up and coordinate systems together across the federal government. So we've been working closely with them, and then I'm glad that our ties have really grown through the pandemic, and now we're doing lots of other great work together. So next, we're going to talk a little bit just specifically about the role that housing and homelessness impact health. Felt important to kind of make sure we're all on the same page when we're thinking about the mortality. So we'll get there, but wanted to level set a little bit first. So people experiencing homelessness die 12 to 20 years before their housed peers. So this is based on mortality data and specifically some of the great research that's come out of Boston Healthcare for the Homeless program. And they've looked at these retrospective analysis of mortality. But what is really shocking and what I want to make sure that we're holding on to here is that these are not just comparing, like very well populations to very sick populations. Even if you take two individuals from the same community, peers, but one person has experienced homelessness and the other person is housed, that difference of life expectancy is still that stark, that 12 to 20 years. And we're going to get into the why. But housing in and of itself changes life expectancy and takes years off people's lives. So here are just some examples of the connection between homelessness and health. So lack of access to adequate nutrition and specialty diets, just trying to not to access particular foods becomes really difficult when you're eating at soup kitchens. There's often very little choice, especially for those who have diabetes, heart disease, and other chronic conditions that require specialty diets. That's very difficult to access. And then just the daily toll of needing to get in line for meals 3 times a day, the time that requires is profound. The lack of ability to store medications is really challenging. Often folks experiencing homelessness get their medications stolen out of their bags. They get their bags stolen. They might be living in an encampment and that encampment gets swept or cleaned. And so they frequently lose or have their meds stolen, which is just incredibly challenging and disruptive for people's chronic medical conditions, their mental health. They're taking mental health medications, and for their substance use, if they're being prescribed medication for an opioid use disorder or an alcohol use disorder. So just that constant disruption of access to medicine is very challenging. Lack of transportation to get anywhere, lack of funds to access public transportation creates a huge barrier. Vulnerability to violence. You'll see that in the data, but people experiencing homelessness have much higher rates of violence and trauma. Environmental exposures. So one way to think about it is that in any natural disaster, whether it's a hurricane, a fire, people experiencing homelessness are often the first affected. So just the smoke inhalation alone from a fire, often those sleeping outside will be the first ones to start having the negative implications before a fire or anything that's close to that community. For a hurricane, rain starts to come down on encampment and flood and ruin people's possessions. So even from disasters, they're the first affected, often the most affected and the least likely to qualify for any services. FEMA does not replace tents. And so often they can have all of their life's possessions ruined, but just the daily environmental exposures of being in heat, high temperatures, freezing temperatures is just incredibly difficult and puts a high burden on chronic conditions like asthma, COPD, and causes a lot of skin conditions. Lack of access to culturally appropriate care is a huge challenge. And just the overrepresentation of Black, Indigenous, and people of color in the homeless population is a huge structural challenge, and often the services are not designed to meet the unique needs of that population. And then simply just not having a consistent place to sleep, what that does to your nervous system, that need constantly of trying to figure out what is the safest choice for me tonight, every single day, and just that burden of fight or flight and that chronic stress certainly is negatively affecting their health long term. So these are just some examples of many, but I think they help to really demonstrate how interconnected housing is to health. So here's an example of a long-term impact of chronic conditions. So often people experiencing homelessness have a delay in initial diagnosis, and this can be anything from hypertension to cancer. Again, because of just that need of needing to get access to food and shelter, often people aren't prioritizing their health until it becomes the top of that priority list. And so preventative care is usually so far down that list of people aren't coming in for routine checkups. So what was initially hypertension for many years is hypertensive urgency or emergency, where they have really severe headaches, are passing out, end up in an emergency department. So delayed diagnosis of hypertension, and then cancer similarly, where people aren't getting routine screenings, and then they don't seek treatment until they have a really significant burden of illness, really significant symptoms. And then once they're diagnosed, there's a high barrier to treatment, as we discussed, around transportation or just not sleeping in the same place. Accessing a medical appointment is difficult for a number of reasons. And then they can lead to exacerbation of illness because of that lack of access to treatment, that high symptom burden, which can go on to cause disability. So what was functional hypertension, someone could get up and go to work every day, now with dizziness and headaches makes it incredibly difficult to function, which can then go on to cause a psychological toll, depression, complication of chronic conditions, and then we add the compounding impact of social drivers of health and lead to multi-organ involvement, and then inequitable health outcomes, which can lead to early death. So you can see really easily where that 12, 20-year difference comes in, where you have these barriers to care all along the entire continuum of health and well-being. But here are the numbers to demonstrate that. So even when we just compare people experiencing homelessness to those who are housed, the burden of these chronic conditions like diabetes, hypertension, coronary artery disease is almost twofold for everybody. And then in relation to infectious illnesses like HIV and Hep C, the difference is so profound. 1% in the general population for HIV, 20% among people experiencing homelessness, hepatitis C, 1% versus 36, depression and substance use. The disproportionality is just exponential at that point. And so I don't expect people to remember numbers, but I just wanted you to see across different conditions how profound the difference is of burden of illness in this population. And we'll see that often it becomes trimorbid, those that are experiencing chronic health conditions and mental health conditions and substance use disorders. And then even amongst this population that is at high risk with this high burden, there is a profound difference between those that are sheltered, sleeping in shelters, and those who are unsheltered. So there are lots of reasons why people choose not to go into shelter. Often if people are gender diverse, a lot of our shelters are gendered or binary, male, female, and people who are gender diverse don't feel comfortable. If people are partnered, if they are a married couple, almost no shelters take gendered a couple into a shelter. They go into different parts of the shelter. If you have a pet, your pets aren't allowed. If you've experienced trauma in a shelter, which many people have, they feel distrustful or they have PTSD and they don't want to return. So there's a number of reasons why people don't want to access shelter in the first place. But when those individuals are unsheltered, they're at much higher risk of having physical health conditions, mental health, substance use, and disproportionately all three. So in this figure, the California Policy Lab look at this data across California. And I thought this was a really good illustration on the right, just showing that of those experiencing homelessness, 2% of the homeless population are trimorbid, and 50% are trimorbid of those who are unsheltered. So this is just a profound disparity, and these patients are so ill and are so complex and have so many barriers to accessing healthcare. All right, so now we're going to dig into a little bit to the mortality data. So we can't address what data we don't have, right? And so this becomes really challenging. We have no national standard for collecting mortality data and housing status. And so what we have is this piecemeal approach where it's kind of city by city, some counties and very few states collect mortality data and also collect housing status. So we're going to walk through some examples of cities or counties that are doing this mortality data reporting. So in 2019, we at the council initiated a homeless mortality work group to really try to work on better data collection, because we really felt like if we don't understand the drivers of mortality, how can we really develop strategies? I mean, we need the data to do this well. I mean, we have anecdotal data, but anecdotes don't change policy. They don't change funding. And so that makes it really challenging. So this was a group of researchers, advocates, public health department officials, health center leaders, clinicians, government officials, and all different kinds of communities involved in homeless mortality review. And this group developed this homeless mortality data toolkit, and that's linked here in the notes as well. And this toolkit shared the counties and cities and states that are tracking this data and share some of the findings from those mortality reports, which we're going to go into. But it also then tries to set a standard of how we collect that data and some roadmaps to how to get started doing this work. Because right now, only 2% of counties are represented. So you have this tiny sliver of this ginormous pie, and we really need to get our arms around the data. We think that counts are really underrepresented. So what we found, like I said, we have no national standard. So we identified that there are 68 cities and counties who recorded the deaths of people experiencing homelessness in 2018. So in 2018, they estimated that there were 5,800 individuals who died while experiencing homelessness. But again, that only represents 2% of the entire of all the counties in the country. So each death count report by a city or county likely misses many deaths each year because the decedent's housing status is unrecorded. It's incorrectly recorded as housed, the death's not investigated by a medical examiner or coroner, or the death is unknown by community members who are compiling the homeless death count. So these are data sets that there's no interoperability. Like we might know all those who are experiencing homelessness based on either our once a year point in time count or through HMIS data, which is the national system that people use to track where people experiencing homelessness are accessing services like through shelter. So we have a list of people experiencing homelessness in geographic locations. And then we have a list on a local level of people who died, but we have no way to cross-matching. Not no way, because we're going to go through some counties that are doing it, but it takes a lot of work to put these together. So part of what we're doing is trying to work with coroners and cities and counties and states to say what should be reportable when we're creating those death records and putting housing status. So a rough estimate of the proportion of people experiencing homelessness who die each year can be determined using data from jurisdictions that count both a death count and a homeless point in time count. So those are the two data points I was mentioning. So just for further, if you're not familiar with the point in time, so once a year in January, jurisdictions across the country literally try to count all the people experiencing homelessness. So they count everyone in shelters. They have teams that go out into encampments. They pull data, they look at people in the emergency department. You try to have a best estimate. As you can imagine, this is an undercount because many people who are experiencing homelessness are doubled up or couch surfing. So we may not, we don't go into every housing or apartment unit across the country. We know the point in time is a really helpful tool, but it is imperfect in its nature. Yes, I agree. Many different data sources. So based on the 27 jurisdictions with this data from 2018, a range of mortality. So of those that reported the data, we have a range of mortality for people experiencing homelessness between 3% and 8%. So that's dividing the mortality count deemed homeless through the point in time count. By applying these proportions from 27 cities to the national point in time count, it's estimated that between 17,000 and 46,000 homeless deaths occurred in 2018. All right, so that's a lot of numbers. So let's pause there for a second. So we're going to extrapolate. What we're trying to do is to try to create a national estimate of mortality for people experiencing homelessness. So we're using the data from the 27 jurisdictions that do this mortality reporting. We're going to take that range of 3 to 8% in the homeless population, and we're going to apply it to a point of time. And what we said was between 17 and 46,000 on rough estimate of homeless deaths occurred in that year. So 5,800 deaths are known, upwards of 46,000 deaths among people who are experiencing homelessness are estimated, which highlights the vast and largely hidden scale of homeless deaths in the United States. So that's kind of just wanting to set the scene. And then we're going to just walk through a few examples of some mortality reports from certain cities. So here's Los Angeles. This report looked at, so this is from, they just reported this, sorry, this report was just published in 2022, but it's looking at the data from 2020. So this is a little challenging because the point in time count did not happen in 2021. So because of COVID, and so they couldn't find in a numerator. So the amount of people actually experiencing homelessness. They do have the report on how many people died who are experiencing homelessness. So in LA, in 2020, the leading causes of death, number 1 was overdose, second coronary artery disease, number 3 was COVID-19, traffic injuries, homicide, and suicide. So I just want to juxtapose that with the leading causes of death in the United States. So leading causes in the US are heart disease, cancer, COVID, accidents, stroke, and chronic respiratory illnesses. So other than accidents, all of them are infectious or chronic health conditions compared to for people experiencing homelessness. These are many of them are preventable deaths. And in LA, you can see the number of people, the number of deaths is really skyrocketing. If we look at the numbers of 2020 compared to 2019. And even when we take out the COVID-19 numbers, they're still profoundly increasing, really around overdose deaths in particular. So overdose by far is the greatest contributor of the increase of deaths. It increased by 78% from pre to post-pandemic year. And this is across age, across race, and across gender. In fentanyl and meth, were disproportionately overrepresented in this population. And we know this increase in fentanyl involved deaths was relatively similar across all groups. And so this is the sad reality that fentanyl is just driving mortality in this population. And we see similarly in San Francisco, more than twice as many people died while homeless in the year starting March 17th of 2020 compared to any prior year. And most of the increase associated with overdose rather than COVID itself. And so actually, and when they look through their coroner reporting, that none of COVID-19 was not a cause of any of the deaths, which is a little hard to understand, but really in 2020, what was this driver was overdose. And so you can see in 2020, this is this gray line, this trajectory, and how the number of people who died doubled. So just such a profound difference. And then 2021 is on track to surpass. Just looking through your questions here. Is most of the data like point in time counts done as aggregate, or is at least some of this data collected by about individuals that would enable correlating the experiences or situations of individuals and then correlation to homeless deaths?
And Courtney, it's your choice
Yes.
if you want to answer the questions at the end or during. We can wait, but we'll just chat questions.
Yeah, I think some of them will try to fold in. So around the point in time count, so these are done hyper locally and they do have some individual level data. So what happens is that local jurisdictions then report this to HUD, and HUD creates the AHAR, the Annual Homelessness Assessment Report. And so you'll have to dig into the actual COCs within states to get some of that individual level data. But what we get from HUD is this aggregated national data that kind of reports on trends and state level findings. So it is hard to think about how we could do that, then correlate a national point in time count to the deaths, because that data is collected locally too. So lots of challenges. And then Christina asks, have the data indicated any difference in mortality rates where there were opioid interventions like widely available Narcan? So this is one thing that's really, we're going to think about this a little bit, Christina, of some interventions. And yes, it's hard to know. So of those that overdosed, the number of people that overdosed, if we go back to the previous slide, there are thousands of people that overdosed that didn't die, that were reversed. And many community reversals, we don't have an ability to track. We can track how much Narcan goes out into a community based from individual level health centers, how many Narcans do we give out, needle exchange programs, how much Narcan got into a community. But then community members are often reversing each other. People using drugs are often the front line to reversing overdoses, because our programs are open from 8 to 4, sometimes in the evenings. But our teams, all different types of outreach teams, are often not the ones doing the reversals. And so it's really hard to enumerate how many people are receiving Narcan. But yes, Narcan saves lives, and we need to be flooding all of our communities with Narcan, because an opioid overdose is reversible. And we want to make sure that people aren't using alone. And so those are some of the particular circumstances of why people experiencing homelessness die, because they're using in the streets, often having to go to less safe places to use away so no one is seeing them. So that isolation is driving death in and of itself. And that's why we're going to talk a little bit about safe consumption spaces. We're not there yet. We'll get there. So one of the things I want to do and highlight some of the different mortality reports is each jurisdiction presents data a little differently, and some is really interesting. So part of what San Francisco does is they do some geo mapping of where people experiencing homelessness died. And so that way they can really target their interventions to those local communities. And we're going to talk about what San Francisco is doing with this geographic data. And so they're trying to literally map where every overdose, where every suicide, homicide, or accident happens. So that way they can say, is this a structural problem where we need to make our sidewalks and crossing streets safer? Is this an area that we need to have our outreach teams going out to provide Narcan? Really thinking through the specific cause of death, mapping it with geographic location. So that, I think, is a really innovative model that San Francisco is doing. Minnesota has a statewide report. So it's one of the very few statewide reports. And I just wanted to show their data sources and how they crosswalked this data, because they did use the Minnesota death data and compared it with HMIS data and compared it to just Minnesota population data. But what they found is that for deaths related to substance use were 10 times higher amongst people experiencing homelessness than the general Minnesota population. So that 1 in 10 substance users in Minnesota are homeless, and that 1 in 3 of all deaths are caused by substance use, specifically fentanyl. So this is just such a huge challenge. And I just want to mention that substance use and homelessness are bi-directional. And so sometimes we'll have someone who falls on hard times. They lost their job, they lost their apartment because they lost their economic stability, and they're experiencing homelessness, and they're really struggling with their mental health and well-being, and they start to self-medicate and they start to use substances. And so homelessness itself can be a driver of substance use. And then inversely, we see people experiencing substance use who go on to struggle with substance use disorder. That can go on to cause that economic challenge and can be a driver of homelessness. And then when someone is experiencing homelessness, they're disproportionately experiencing the negative impact of substance use. And so one way to think about it is if I were to have a glass of wine in the comfort of my own home, if I have one too many, I can just sleep it off. I'm in my home and no one sees what I experienced. If someone is experiencing unsheltered homelessness and they are too intoxicated, they might fall down, they might get taken to the emergency department, they might be incarcerated. So they disproportionately experience harm related to substance use, even if it's similar substances than a housed population. And again, like I mentioned, people end up having to use in less safe circumstances because they don't have a space to use safely. So one of the differences of the Minnesota homeless mortality report is they really drill into some of the detail of external causes of mortality, anoxic brain injury, suicide, homicide, transport accidents, pedestrian injuries in particular are what I wanted to highlight. On the right is the odds ratio that increased for people experiencing homelessness. So you're so much 7.7 more times more likely to experience a pedestrian injury when you're homeless compared to not, and then a transport accident of being hit by a car. So these are just such profound differences, and then the rate of violence in terms of homicide. So these are, I know these are hard, these are sad statistics. We're going to move beyond just all of the sadness for a minute, but this level of detail is really helpful because the structural response to pedestrian transport causes of death are going to be working with your city planners. It's talking about where people sleep and what are happening at those intersections to really decrease those pedestrian injuries. And so obviously housing people is what's needed, and the built environment is also causing these drivers of increased mortality. So there's not going to be a one size fits all to decrease mortality for overdose, for homicide, suicide, pedestrian injuries. They're all going to be uniquely different. This is a report from Multnomah County in Oregon. So this is the last one we're going to review. But what I wanted to just show is what they illustrate in particular is the location of death. So where the death actually occurred. And this is striking to me that nearly 50%, 47% of individuals who died while experiencing homelessness died outside. And that to me is heartbreaking. And it tells us where we need to take our services, that these clients, if they're injured, if they're struck by a car, they're not making it to the hospital. And so how do these overdoses are often happening outside. So that to me is indicating we need to meet people where they are. So other locations are hotels, motels, RV campers, rivers. People are outside when they're experiencing homelessness. And so we need to think of how our healthcare systems are reaching these individuals, reaching beyond our health centers, beyond our hospital walls. I'm going to come back to that data question. All right. And so in all of the mortality reports that I mentioned from LA, San Francisco, Minnesota, and Multnomah, each of them had suicide as one of the causes of mortality in this population. One of the things I want to mention is that the CDC has surveillance data. It's called the CDC surveillance data of violent deaths. And there's an MMWR that I'm linking to below in the notes here. But if they looked at some of the life stressors that drove suicide when they are doing these retrospective analyses, I just wanted to write out, I took a screenshot of the list here. And what was really profound to me, so this is national data. This is not specific to people experiencing homelessness. This is for all suicides nationally. What you can see is so many of them are particular to people experiencing homelessness. So crisis in the previous or upcoming 2 weeks, physical health problems, conflict, job problems, financial stressors, recent criminal or legal problems, eviction or loss of home, history of abuse or neglect, physical fighting, traumatic anniversary, exposure to disaster. People experiencing homelessness disproportionately experience all of these life stressors. So we can see how complex and why there's so many drivers of suicide in this population to make it really challenging. So to your question, yes. So those who ended up in the emergency department, there's different models for that, but not every ER lets the health center or the healthcare for the homeless clinic where these individuals receive service know that that person ended up there. But I'm going to talk about a model that San Francisco is using to try to provide that closed loop referral or that closed loop offering of care. So we're not going to get into each of these, but I wanted to put them here. There are some big studies that really are kind of the most foundational to this work that I wanted to list out for you all. And one of them is just the research is showing that drug overdose mortality has increased substantially over the past 20 years in the US, but disproportionately affecting people experiencing homelessness. And so these are all kind of the major studies in this area. So I just want to make sure that folks have those. All right. Ooh, so I know it's a lot. It's not easy. It's not easy to have these conversations. And the reality is that people that work within healthcare for the homeless clinics are on the front lines of these compounding crises of really a crisis of a lack of affordable housing, crisis of overdose, crisis of deaths of despair. It's a lot. And there's some communities doing really beautiful work. And there's some really fantastic strategies that are being implemented that I want to share. So first and foremost, housing saves lives. It feels important to just get that out of the way. Like housing literally saves lives, it prolongs life. And the shorter someone's experiencing homelessness, the more that we can impact their long-term health. We see, I before coming to the council in my local healthcare for the homeless clinic, well, I still work there now 1 day a week, but when I was there full time, I was the primary care provider that provided outreach to our Housing First sites. So Housing First is a type of housing that's low barrier housing for people, harm reduction based, so people don't have to stop using substances to get housed there. But it's really designed for people who, or they choose people that are often the highest risk, those that might not make it into their winter. So often it's people that experience chronic homelessness, that are trimorbid, that are really ill. So we put this kind of high risk population, the highest risk of the highest risk in housing. It is a sick group. And often if they've experienced homelessness for 20 years, so much of the care that I'm providing is palliative at that point. What we want to do is get to a point where we have enough housing stock for people where homelessness can be rare, brief, and non-recurring. And we can really get people housed before they face these long-term health implications that they experience because of homelessness. So I wanted to put this here. This might be for some people and not for all. It's a little busy, but for me, when I'm thinking of interventions as the clinical director at the council, I'm thinking of the 1 million people experiencing homelessness. I'm thinking of the 300 healthcare for the homeless health centers and how we work across the federal government. And then how do I make sure that each individual person receiving care at a healthcare for the homeless clinic is receiving really high quality care. This is the framework in which I'm thinking. I'm thinking of the micro level of that individual interaction. How do I train and help the healthcare providers do great work? Make sure that they have all the training and research needed to do that work. How do we think on the community level to reduce vulnerabilities and increase partnerships across the community level of knowing healthcare can't solve this alone? We need our housing partners. We need our shelter providers. We need our public health. So we need partnership to be able to tackle these things. And then public policy. How do we work across the federal government to really improve policy to decrease homelessness, to improve access to healthcare? One example is that we just passed in the omnibus bill at the end of the year, we got rid of the X waiver for Suboxone. For so many years, Suboxone was seen as, Suboxone is a medication specifically used for opioid use disorder. Profound years of research showing that Suboxone saves lives. And we had this special training that prescribers had to go to be able to prescribe that medication. So I could be a primary care provider and I can prescribe oxycodone, fentanyl, I can prescribe all the opioids, but I had to go through 24 hours of training and get a special X waiver from the DEA to prescribe Suboxone, which is a highly safe, highly regulated medication. After years of advocacy, we at the council worked with many other advocacy organizations to say we need to get rid of the X waiver. We need to mainstream substance use treatment. We don't want to have substance use treatment or opioid use treatment only in specialized centers. This needs to be integrated into primary care. We need to see people as whole people. We want family medicine and internal medicine providers to be able to treat hypertension as well as opioid or alcohol use disorders. And so fortunately, the X waiver just got eliminated. And so that's one way in particular I'm thinking of how do we get rid of the structural barriers? How do we impact public policy to decrease the barriers to care and increase access to treatment that will then impact that individual level. So I'm often trying to think of how do we create interventions at each of the individual, medium, and public, in the macro level of public policy. So one way that I mentioned is through partnerships. So through the pandemic, we really have this three-legged stool at the federal level with on the healthcare side, we had HRSA, the Veterans Administration, and us at the council, working with public health, CDC, and with homeless service providers at HUD and SAMHSA. And USICH is one of the bodies that brings all these organizations together at the federal level. But really the technical assistance providers, the experts that are really doing the work and all of these, we would meet weekly to really coordinate our efforts. And we hoped that that would be a model and trickle down. And we helped to support this on the local level. We put out a lot of publications around at the city level. How do we make sure that our FQHCs are partnering with your hospitals and your VAs, and then across to public health, and then across to homeless service providers? We knew it's just become obvious, so much more evident now that within this space, we can't function individually. We can't improve health outcomes without addressing both homelessness and health. And so therefore we have to work together across these systems to do that well. So here is the healthcare for the homeless model. So one of the things that differentiates 330H's from other 330 grantees, other health centers, is that we're mandated to require integrated primary care, substance use, and mental health treatment, knowing that those are disproportionately experienced in this population. So this model started 35 years ago in the 80s. Initially, the Robert Wood Johnson Foundation funded 19 pilot sites across the country, the initial 19 healthcare for the homeless programs. And really way back then, before it was like hip, we were doing multidisciplinary care and medical outreach, providing care to people in shelters, on the streets. And so we've been doing this work a really long time. And now it's like finally in vogue and people are like, oh, it's really innovative. We're like, oh, we just threw on a backpack and just went to go see people in their tents. But yeah, it is a really good idea to provide care to where people are, not just within our health centers. So really it's trying to meet people where they are, providing care beyond the walls of the health center. I'm going to give some specific examples of what that is, but part of it is medical street medicine, medical outreach, medical respite, and I'm going to define that, and shelter-based care. So really thinking of where are people experiencing homelessness and how do we bring healthcare to them? And then some of the foundational principles are trauma-informed care, right to self-determination, harm reduction, and just the principle that every person has inherent dignity and worth. And so I know that these shouldn't be novel, but unfortunately they are. But I'll say that providing compassionate care can be some of the most important healing that we can provide to someone, much more than a medication. And so I'm always in my own clinic practice grateful when my patients come back. I'm like, oh, this means they felt cared for and that they felt supported, regardless of the challenges that they might have and the barriers to care. They should back up. So it means that we're doing something right. So this is just an example of a multidisciplinary team. This is what I have in my health center, my healthcare for the homeless program. Primary care provider, we have a registered nurse, a medical assistant, we have a peer support, a licensed clinical social worker, and a case manager. And then we have other services, we have dental, we have psychiatry, our PCPs are our substance use treatment providers, we have infectious disease specialists. So every HCH is going to have a different combination, but it is a multidisciplinary team and really a fairly flat system. We are not hierarchical. We know that, I know for myself, the peer support of my team is often way more important than me as a prescriber, because that client wouldn't come in the door if it weren't for the peer support. They have a deep relationship. They've known each other a long time and they trust each other. So often that peer is just as important as me as the primary care provider. So that is such an essential part of this team. Oh, great. So this is what we're working towards, building a continuum of healthcare. So we see that health centers are one part, but we want to make sure that people can access care and not have to leave one silo and enter another. And so we're trying to create bridges with hospitals and partnerships with hospitals, as someone mentioned in the comments. We have some programs that have a community health worker liaison in the ER that is funded by the health center. We have medical respite programs that receive referrals directly from the hospitals. We have teams that go to shelters and teams that provide street medicine, and all of it hoping to be an intervention to connect people to supportive housing. So medical respite or recuperative care in particular is a model that is unique to healthcare for the homeless. Well, the VA does it too, actually, for this population, but is really post-acute care for people experiencing homelessness who are too ill or frail to recover on the street, but not sick enough to need to be in the hospital anymore. So these are people who just had surgery. They have really horrible wounds. And if they go back to the shelter, they're going to end up right back in the ER because they really don't have the ability to recuperate because they have to be out at 7 a.m. from the shelter. So really, it's a really vulnerable time. And we know that people experiencing homelessness have length of stays twice as long as the general population in the hospital. So hospitals have a lot of interest in this in particular. So recuperative care provides short-term residential care that allows people the opportunity to rest, recover, and heal in a safe environment while accessing clinical care and supportive services. So there are about 130 programs across the country. It's really fascinating. The growth has been exponential because people are seeing this as such an important part of the healthcare continuum that is missing in most places. We have programs as old as Barbara McGinnis in Boston, and it's been around since the mid-'80s, and we have programs that are opening. My program here in Portland opened in September, but they all vary significantly in how many beds they have, the facility type, length of stay, staffing, referral sources, and mission criteria. So if you want to do a deeper dive, we at the council have a special initiative called the National Institute for Medical Respite Care. I'm sorry, recuperative care and medical respite are used interchangeably, so I go between both. But there is a ton more information on this model, and it's really fascinating because this is one area where managed care is really interested. This is an area where state Medicaid programs, hospitals. So there's a lot of energy at the CMS level around how do we fund this? Is this housing? Is this healthcare? But people are seeing such profound benefits. It really helps to reduce cost to the system, improve health outcomes, and certainly reduces length of stay for many patients. And I'll say for my own program, we just opened in September, and 60% of our patients that get discharged from our program have gone into housing. And so it is an impactful intervention for ending homelessness because people can receive those wraparound clinical care while receiving case management, and they're really in a prime opportunity to address their social determinants like housing, which is a heavy lift in the community. Melissa, great. Thanks for raising that. Medical respite program in my community in the Bay Area have been profoundly helpful in being an option for care for patients who we see in our ethics committee, moving them out of the hospital and reducing time between admissions. Absolutely. It's often really complex patients with nowhere to discharge to. And so to be able to have them know that they're going to go to a safe place that's much less expensive. And often these clients don't need hospital level care. That's the point. And then Doorways and NFP and St. Louis, Missouri is a model of best practice for recuperative care for the homeless, originally beginning to address HIV and AIDS. Thanks for raising that, Janet. Yeah, there's so many wonderful examples, and each of the drivers of each program, the program designer, are all a little unique. Where the program that I just opened here in Portland, we have a really high percentage of people who are using IV drugs who want to have infections like endocarditis, spinal abscess, osteomyelitis, and that requires 6 weeks of IV antibiotics. But if I had an infection like endocarditis, after a few days in the hospital, they would discharge me home with visiting nursing, and I would get that antibiotic at home. But for people experiencing homelessness, they have nowhere to discharge them to, and so they end up sitting in a hospital bed such a long time, and they end up self-discharging because it's awful to sit in a hospital bed that long. So really, really expensive intervention, not very effective, and then they end up cycling back and forth to the hospital. So sending folks in my program, having them come to recuperative care has been such a huge success. And there's some good data that came out of the University of Washington and their St. Edward Thomas House that that they wrote a paper specifically on their outcomes around recuperative care and IV antibiotics. That was really profound. Just wanted to, another innovative model around medical outreach. Street medicine programs are growing exponentially as well. It's really exciting. Under CalAIM in California, they are funding street medicine for teams to be able to provide full scope primary care in the field. So it's really doing physicals, prescribing medications, using iPads or phones, doing point of care labs where we can get hemoglobin A1Cs, Hep C testing, HIV, all those rapid labs, and ultrasounds, doing point of care ultrasounds, as well as care coordination. So really taking that multidisciplinary team model out into the street to provide care on site. We have other programs that are geographically really large, like Alameda County in California. It's a huge geographic area, so they utilize a lot more mobile units to be able to go to different parts across the county. Street Medicine Institute is like a partner, brother organization to us at the council. We work really closely with them. They have a lot of great resources too, if you want to dig more into the model of street medicine. So here's what I wanted to just share. So when we're thinking of actually trying to decrease mortality, we're trying to think of decreasing rates of overdose. There's so many things that we can do. And again, going back to that model, it's the World Health Organization model of addressing social determinants of health, is thinking of what do we do on an individual level, on the community level, and in the public policy level. And there's lots of things that we can do. It's increasing access to mental health care, accessing Narcan, increasing the number of substance use treatment providers, decreasing barriers to treatment. That's a lot of internal policies within programs. If people show up and they want treatment today, how do we get same day access rather than saying, here's your appointment for a week or a month from now? Really working on addressing social determinants of health and seeing housing as such a huge driver of overdose death. And safe consumption. This is even something that we are strongly advocating, to use every public health tool in the toolbox. And On Point in New York City is the first safe consumption site in the United States. There are globally hundreds of safe consumption sites where individuals can bring drugs to a site and safely use under the observation of peers or clinical staff. And if they have an overdose, they are reversed. There's been over, I think, 600 reversals at On Point in New York City using Narcan. Not a single person has died. And that bears out in the literature of overdose prevention sites globally. I don't think there's ever been a documented death within a safe consumption site because they have all this robust support and ability to reverse people, and people who engage in harm reduction, those that access safe supplies, those that go to needle exchanges, are 3 times more likely to enter into treatment. So often what we say is the opposite of addiction is not sobriety, it's connection. Social connection is such a huge driver of helping people move forward in their recovery, and really trying to utilize all harm reduction practices, meeting people exactly where they are in their use, because we can't help someone if they've died. We want to just help people be safe in the moment while we work to address whether it's the underlying mental health, or we want to work on their housing. It is incredibly hard to enter into recovery when you're experiencing homelessness, the stress, or the exposure of other substances. So really, how do we support people being safe until we're able to move them into housing? And so these are all the different ways that we're trying to work on these issues. And we're going to open up in a minute for questions, but the last thing I wanted to, innovative model I wanted to share is what San Francisco is doing. So we showed the map, how they're mapping their mortality. So what they've done is they have brought their healthcare for the homeless team and paired it with their emergency response team, their EMS. And so now what they're doing is they're providing real-time response to individuals who've experienced a non-fatal overdose and who are identified to have opiate use disorder. So from the hours of like 8 a.m. to I think like 8 p.m., you'll have a co-response. So EMS responds to a 911 call and someone has overdosed. The SORT team will show up, and this is the healthcare for the homeless team. So this is obviously specific for people experiencing homelessness who've overdosed. And that team on site will say, do you want Suboxone or methadone? Because actually, if someone has just been reversed, you can safely start Suboxone. So they'll try to provide in the moment treatment for someone, because those who have overdosed are the most likely to overdose again. And if that person says no in the moment, they say, okay, no problem. My name is Courtney. It's really nice to meet you. I'm going to follow up with you in a day or two to see if there's anything else I can do to help. And then they hand off to the post-overdose engagement team. And this team follows that person for an entire year, offering services of substance use treatment, access to mental health care, and case management, and really working on housing. They offer harm reduction supplies in the moment. Here's some Narcan, here's some new needles. How can I support you today? And in particular, they're trying to address the racial inequities of overdose deaths in California and San Francisco by collaborating with organizations that work with BIPOC communities and people who use drugs, and all sorts of staff have received training to improve healthcare system trust. So this is such a beautiful example of how one city used their data, did this geo mapping, and said, of those that are overdosing, it's mostly amongst our homeless population. So if we want to, part of their prevention plan is to create this dual response, and then to provide this ongoing follow-up, because that is the highest risk group and they've identified them. So it's really getting to what we talked about, is like, how do we can't track how many people are being Narcaned by other community members, but we can co-respond. And so I thought that that was a really amazing, innovative model. And Barry Zevin is a psychiatrist who's the medical director overseeing their outreach team, who is really leading this. So it's really exciting. It's brand new, and so we don't have the data outcomes yet to be able to demonstrate. But I did put a link in the notes around San Francisco's prevention plan. In addition to this model, there's lots of other, obviously, components, and housing being a big one of them. And then lastly, our conference. We have our conference coming up in May in Baltimore, and we're offering a lot of sessions and deep dives in these particular topics. So we are partnering with the National Harm Reduction Coalition to do a pre-conference institute, which is the one-day deep dive in harm reduction, really thinking about how we work with syringe service programs, how do we make sure all our health centers have Narcan, decrease barriers to care. So we're really excited about that partnership and that PCI. And then in our learning lab, we're doing a half-day training around homelessness and suicide prevention. So really trying to say, what are the main drivers of mortality in this population? How do we align some of our conference, our training, and technical assistance to squarely address those causes of mortality in our community? Yes, I will certainly share that registration for you all. And maybe we'll, during the Q&A, pull up the link as well. All right, I did it. That's it. So I'm going to take down the screen, and I'll put my email in the chat if folks have other questions, or if there are particular resources that people want me to share. But I'm going to pull the registration for everybody.
Just wanted to reiterate, Courtney, thank you so much for this presentation. As you mentioned, very important topic, but also a very difficult one to learn about, and learning more about the challenges this homeless population faces. I would like to invite everyone, if you feel comfortable, please go on camera. Let's have this be a discussion. Please let us know if there's other questions you have, either put them in the chat or feel free to speak up and ask your question.
I'm going to also add, so I have a link for our conference. I'm adding a link to our mortality toolkit, so those can access that as well. Go ahead, Jessica. Hi.
Yeah, when you tell Courtney each person where you live, what you do. I know she's very interested. So.
Hi, Courtney. This is Jessica Bearhorst. I am from Aptive Resources. I'm in New Orleans, and so we have a big issue with homelessness here, and unfortunately not a lot of resources that go around. One of the things that I think we see in our community is that, especially for community resources, substance abuse tends to be a barrier to entry. So if you have to go into a substance abuse program to be able to benefit from temporary housing or other things like that, how do we work on sort of a community level to solve that, so that it's not a barrier to entry, so we can get folks into some because it's sort of a chicken and the egg thing, right? Yes. We have to solve the substance abuse to be able to keep folks housed, but we can't get them housed if they're suffering substance abuse problems. So what are some tactics or strategies that you think would be helpful?
Yes, this is an essential topic. So obviously there is a whole ethics moral argument that doesn't really help move the needle on public policy. But there is stigma that we need to break down for this. But I personally, I have found the most profound intervention that can help move the needle is the data, the research, and cost savings. Honestly, so for example, like our medical respite program is specifically designed for a high level of care on people who use drugs. And initially, the hospital wanted to pay for as much security. They wanted to have more security than nurses. And it took really helping hospital executives understand this population of what is impactful and what models work best. And so we see a lot of local city councils, even state legislators, think that we're helping people by having those sobriety requirements. And just honestly, as a society, we are more comfortable with sobriety. It just is a black and white that we can understand, and saying like, okay, we should at least have this requirement. It means people are serious about their recovery, or they're serious about housing, or they deserve. And unfortunately, those policies are developed in stigma, and we just have a moral judgment around people who are using substances. And so I think trying to not even squarely address the moral or ethical argument of saying, here is the research which shows if we house people. Massachusetts had a great study that said if we just house people, it will save the entire system $20,000. People won't use the ER as much, they won't have as many psychiatric admissions, they won't be incarcerated as much. And that's what helps move public policy. The thing, this is a very effective intervention that has 30 years of robust research. And here are the dollars and cents to back it up. And that's what I have found is much more profound than saying, come to my side and let's talk about why this is the right thing to do. Unfortunately, I think it's true though.
Thank you.
And to piggyback off that, I just learned of a great program in Miami doing harm reduction, and they're doing syringe service and providing street-based Suboxone. And I asked the same question to that psychologist of how the heck did you get this started in Florida in a program in a state that is hostile to harm reduction? He said, I didn't talk about harm reduction. I talked about cost savings. And he's like, and that's where he got people on board. And then when people came, they saw the impact, and they saw that these are humans that are benefiting from the program. So it was the dollar and cents, but then also showing the human side of this piece as well.
And Courtney, we have a question in the chat from Niall. Great question, Niall. But this is really tough work. How do you care for your workers and combat burnout among workers at your organization?
Whew, hard one. I've been doing this work 12 years, and it's my life's passion. And I've gone through periods of burnout and stress myself. And it's something we think about a lot of how we help the health centers do this work. Just connecting with other people that do this really helps. And so really creating peer learning spaces. Often if you're a healthcare for the homeless program, you might be the only one in the city. There's usually just one. And so you could be the only nurse or the only psychiatrist or the only peer support doing that specific type of work. But helping people connect to other peers or other nurses really helps, just to have someone that gets it, that really understands what the challenges are. And I mean, I think the reality is that there's like so much beauty in this work too. It's like when patients who are so socially disconnected, when they often don't have families, to create an environment where people feel cared and supported. I mean, that fills up my cup when the patients come back and are just so, my patients are the most generous and are the most grateful. I get more presents, people experiencing homelessness than any other aspect of my life. I mean, that is just really affirming. I will say what burns people out the most is pushing back against inequitable systems. It's the system that burns and grinds people. It's not the patients that we serve. And so how do we help remove those systemic barriers? If I have to be on the phone waiting for prior authorization for a medication forever, it just drives you nuts. You know, you're like, I have all these patients I need to be seeing and the work I need to be doing. And it's so frustrating when you know people deserve housing, they need housing, and there's no housing to be found. I mean, that's just, those system inequities are what are really challenging. So the other piece that I really support health center staff getting involved with is advocacy. It really helps if you are doing your direct service, you're doing your work, but also know that you're working to actually change policy. So we do trainings on how to go to your city council, how do you go to your state legislature, how do you testify, how do you write testimony, to help bring that data and that patient voice and those stories as providers. Because unfortunately, not so unfortunately, but legislators listen to people with credentials. You know, if you have an MD next to your name, if you are a psychiatrist, legislators listen to you. And so we try to get those staff to go and testify, to share what it's like for you to do this work and what they can do to address policy. So helping to work on the system while you're providing direct care can really be an antidote for burnout, knowing that you're working to address the system long term.
Hi, Courtney. This is Kay. Hey, I was wondering, you know, our teams, one of our teams has been doing some mortality analysis vis-a-vis suicide prevention in the veteran community. And when I saw your model for San Francisco and all the interventions that are being done, has there been any mortality analysis done for as far as suicide prevention or anything like that in any particular any one of these cities, whether it's San Francisco or LA or any others?
Not that I'm aware of, Kay, and it's really interesting you bring that up because we just had our planning session this morning around that learning lab for suicide prevention, this population. And part of what I was going to do is reach out to some of my colleagues at the VA to see if they can kind of share some of their best practices, because I see the VA as really leaders in suicide prevention space. And it's really not something that we have had a lot of innovation in, or have a lot of, there have not been a lot of models that I'm aware of that are particularly targeting this population.
So we actually do a huge study on their suicide prevention for the much of their really big mental health programs. And we produce a congressional report every year. And so if you need any help with any of those, let us know and we'll be happy to share those with you. The reports are out in the public, but you know, we can send you the link or talk to you more about that.
That would be fantastic, Kay. I'll certainly follow up on that. So timely.
Sure.
I'm going to piggyback off that question, Kay. Courtney, as you know, we do a lot of work with veterans at Aptive across our different lines of business. So work heavily with the veteran population in different ways. Does your organization have any veteran-specific programs or outreach or any data that you can share specific to this population and homelessness?
Yeah, it's so interesting because we serve people experiencing homelessness. I mean, we serve veterans who are experiencing homelessness, certainly, and we don't do anything particular other than try to connect them to their VA benefits and their VA team, because often they're able to access other types of housing that general population are not. And so here locally, we have a VA that they have a homeless liaison that we work with. And so often it's really trying to create those connections. It's providing the medical care. We serve everybody if they're experiencing homelessness, but it's also making sure that they're accessing all the benefits that they deserve. But I don't think we have any, I'm not aware of any particular programs that have like formal relationships with any VAs.
That's helpful, thank you. And there's another question in the chat from Tatiana that she noticed language has been evolving. So what is your perspective on the word homeless versus unhoused or people experiencing homelessness?
Good question. So we tend to just try to use person first language first and foremost. So rather than, you know, addict, we use people who use drugs, or rather than just someone who's homeless, saying people experiencing homelessness, because that is not a fixed status. But the point of someone of saying unhoused is trying to flip the driver of saying that's on society. We are not housing that person, and particularly like intentionally. And so I do think that there is some, often we'll use them interchangeably, but I think it's trying to shift the mindset around they're not just without housing, we're particularly unhousing them, or we have prevented them from accessing housing. But in general, we try to use person first language, but often we'll use a combination of all of them. Obviously, saying people experiencing homelessness is a long, it's a lot, it's a mouthful.
Okay, any other questions? So I have one more, but I'll save it to the end. Opening it up to anyone else who may have questions.
I encourage you all to also look up the directory Healthcare for Homeless programs, just to see where, I know you're all across the country, just to see what local programs exist in your communities. I think often we might not be aware that there is even a grantee in our neighborhood.
Yeah, I guess I had a question, Courtney, I like that you focused on what the federal and state and local governments were doing. Are there other efforts under the new administration? I know that there's an interagency homelessness council and those types of efforts which are getting some extra support, right, and focus.
Yeah.
But I don't know if there are any other things that you wanted that we should be aware of and tell people about.
Yeah, so USICH just released their federal strategic plan, and it's not light reading, it's really long. But for those, if you haven't looked at it, it is really helpful to see where this administration is investing. I think between ARPA dollars, which a lot of communities leveraged for housing, and the infrastructure bill that also leveraged funding for housing, we saw a historic investment in housing. And it's still not nearly meeting the need, and it's not changing the issues around Section 8 as being entitlement. So we know that everyone that can qualify for Medicaid based on just how much money they make can access Medicaid, but not everyone who qualifies for Section 8 can access it. There's, Congress has capped that. And so until we actually address, or we fundamentally change that housing is a human right, all of these policies are falling short because we're so behind on housing stock. I mean, 30 years of historic divestment in housing has created this issue. And so we see crisis of affordable housing across all levels, not just those that are the most economically disadvantaged. We see that for workers, we see that for middle income. And so there's a lot of policy to work on. But really, it's going to take a fundamental shift in the way that we think about housing to address homelessness.
And Courtney, another question in the chat. This one's long. From Nicole, she previously worked at our RRH program through a VA grant, supportive services for veteran families from 2019 to 2022. They received a lot of funding during COVID that made a lot of veterans reliant on their program. And since then, funding has decreased and it put these organizations in a bind. Have you seen the same in healthcare funding? And if so, how has that impacted the amount of work you're able to accomplish?
Ooh, this is hard. We all kind of develop these fiscal cliffs. This is like historic investment in having a vaccine ambassador and coordinating testing, all these people, additional case managers with sunsetting funds has really been a huge concern. And ending of the public health emergency is changing the way people can leverage funding. So we're concerned. We're kind of all white knuckling it to see what happens. And trying to provide some, training technical assistance to the health centers to make sure they're receiving their funding. But there's no new funding coming out right now, so that's what one of particular challenges. I will say HUD did just put out, is particularly interested in addressing rural homelessness, and they are funding communities that are trying to bring in healthcare partners. So they're really trying to invest in communities that are continuing to develop this cross-sector partnership. And so they just came out with their first round of funding for those programs. So there is maybe some new funding, but not a ton. And then in our current administration, that's going to be in divided house, that's going to be particularly challenging.
Thank you.
No, I haven't figured it all out yet. Sorry, I haven't. Super simple problems.
Any additional questions? We still have a few minutes. Before I ask my last question, then just want to shameless plug, we'll continue these series. We'll have other emerging public health topics. If there is a certain topic or guest presenter that you would like to join this series, please let either Jason, Kay, or myself know, and we're happy to make that happen. Thank you, Abby. A comment for Courtney. Thank you for the important work that you're doing. Thank you for being here today and sharing all of this data with us. I did want to end it with one final question, that if there are any opportunities for those of us that may want to get involved to help your organization to further the work that you're doing, what are those opportunities and how can we be a part of this?
Yeah, thanks for asking that, Jesse. I think we are a small organization, and just sharing and disseminating the work that we do is really helpful. And so you can sign up to be members for our listserv, and then share that with your members, with your groups, with your community. And that really helps to expand our reach, because so much of our work is trying to help build partnerships outside of health centers. And so we want other healthcare, we want partners across health systems, the health sector, to get more involved. So sharing our conference information, sharing our publications, all of that really helps. We want to get these messages out. We want to get this training out to all providers. We think harm reduction should be leveraged by every provider in the health system, not just in the safety net. So those kinds of elevating and kind of echoing messages is really impactful. So really grateful for that opportunity.